Thanks, Ben. Chicago has 6 academic medical centers, lots of hospitals, many clinics, and although not quite as many doctors, I suppose, as Boston, because you probably have to spit a lot more to hit one, you can imagine that there's a lot of healthcare in Chicago. And so one of the questions I get asked frequently is, why do you need an echo program in Chicago? So I'd like to use a fictional story about a far from fictional event to try and answer that question. So Sherry, she's a 35-year-old mother of 2, a clerk, and she has hypertension. And she goes to her primary care provider. We'll call him Dr. Prime. And she and Dr. Prime have been working quite hard to try and get her blood pressure under control, but it's just not working. And so Dr. Prime's a bit frustrated. He's frustrated in part because he can't meet the needs of his patient, and he doesn't have the time because of the pressures of the FQHC world, the federally qualified health center that he works in, to be able to attend some of the continuing medical education opportunities that those 6 medical centers and others in Chicago offer. But he's also frustrated because he knows that in order to try and get his patient in to see a hypertension specialist, it's going to take months. And it's going to take months because even though there's a lot of doctors in Chicago, there's an inequity in their distribution. And it actually takes 8 months to get Sherry in to see a doctor because not all doctors are willing to take Medicaid. The doctor that Sherry's going to go see is at the University of Chicago. And Sherry boards a bus from her neighborhood, has to change buses, and eventually it takes about somewhere around 75 to 90 minutes for her to get to the University of Chicago. Now, Chicago has a great transit system, and this is just the time it takes from where Sherry lives to get there. I put up a map showing the gang territories in Chicago. And not because Chicago's defined by the gang territories, but it's one more reason why Sherry's frustrated. She's a little nervous about passing through so many neighborhoods and gang territories, and as a result, by the time she gets to the University of Chicago, she's a little anxious. So she's frustrated, her primary care physician is frustrated, and now she's going to see the hypertension subspecialist, Dr. Reddy. And Dr. Reddy is, as her name implies, ready to see Sherry, but she doesn't have information that Dr. Prime had sent to Dr. Reddy. And so now Dr. Reddy's frustrated. But, she was already a bit frustrated to begin with because more and more of her practice is being spent seeing patients who are complex for a primary care provider, but they're not complex for the academic medical center, which is set up to see the most complex patients. And they're not the most complex for Dr. Reddy. So at the end of the visit, you've got a lot of frustrated people. So the reason why we need Echo Chicago is to lower frustration levels, to try and bridge the social, cultural, and economic distance, not physical distance, that patients have in Chicago, to try and bridge the social and professional isolation that primary care providers like Dr. Prime experience. So in 2009, after hearing about Project Echo, a group of like-minded people, including the person who now has become our executive director, Tamara Hamlish, and I went down to meet with Sanjeev and his fantastic team here in New Mexico. And we spent 3 glorious days learning about the ecosystem. And we then went back to Chicago. And in Chicago, we had some partners. The University of Chicago has an urban health initiative, And as part of that urban health initiative, we have built something called the Southside Healthcare Collaborative. This is a collaborative of federally qualified health centers, as well as safety net hospitals across the south side of Chicago, all working together to address the issues of access to care. And much as we heard earlier that it took about 15 minutes to convince the DoD that this was a good idea, well, it took about 15 minutes to convince the collaborative that this was a good idea. And that's what led to the creation of the ECHO Chicago program. We started with a pilot project that was focused on resistant hypertension, and we were focused on the south side of Chicago. And what we moved to over the last 4 years is what you see before you, which is expansion over the entire city. And we've expanded from 1 program now to 5, and we expect by the end of the academic year to add 2 more programs. And we've been successful because of partnership with the FQHCs across the city of Chicago. We now work with 22 FQHC organizations, and we're in many of their sites. But we're also successful because, well, we do a good job, and people are satisfied. We've been able to measure that people are satisfied with what they're learning, that they use it to help with their self-efficacy. And that success has come in part because we've been able to pick good subject matter experts in their teams to be able to work with the FQHCs. So they know that they have to stay positive, that that's critically important, that they have to draw in the participants so that way there's a lot of interactive conversation. After all, that's part of the success of ECHO. But they're also successful because they know that knowledge comes from everybody who's on that call, not just from them. Now, we've had our challenges too. Every ECHO program does. And we've addressed that challenge through a process of quality improvement that has allowed us to be able to attempt to identify and fix problems. So when we first started, we were kind of shocked to discover that connectivity is a big problem in Chicago. You know, broadband is not democratic. And across the south side of Chicago in particular, there's very little broadband access. So we had to solve that through the use of DSL and hotspotting. So that way we were able to bring sites in. We also needed to deal with the work at FQHCs in order to have the time for people to be able to work together. And so what we had to do there was schedule all of our sessions at 8 a.m. because that's the only time that those providers have the ability to control their lives and be able to participate in ECHO sessions. Sustainability is an ongoing problem, and you know, sustainability is always going to be a problem for ECHO until we are able to stop ECHO as a special program and weave ECHO into the fabric of healthcare in the United States. Now, we've been fortunate with funding. We have local funding from foundations like Grant Healthcare, Fry Foundation, the American Cancer Society's chapter in Illinois, Northern Trust, and the Visiting Nurse Association. And we have national organizations such as Aetna, Baxter, and most recently the American Academy of Pediatrics. But even more recent is that we have funding from the CDC. And we're particularly excited about that because the CDC funding, we are recipients of a 4-year grant that will start next month, $1.55 million annually, in order to build a project that we're calling HepCat, Hepatitis C Community Alliance for Treatment and Testing. And what that will allow us to do is to be able to build a broad-based system to gather data. And that will help us with the return on investment issues that we have to, of course, face because that's what our funders and the sites want. So if we come back to our patient, Sherry, she now, as a result of ECHO, walks to her doctor. Dr. Prime is happy because he is no longer having as much isolation and he's able to meet the needs of his patient. And Dr. Reddy is happy because she's seeing more complex patients, something that's very important to her. So ECHO Chicago is successful because of our value proposition. Patient care, technology, force multiplication, education, and above all else, partnership leads to a comprehensive healthcare system that we can use to address population health. Thank you.